So what I'm going to be talking about is about ultrasound imaging. I've worked in the field for quite a long time. Most of you probably don't know much about ultrasound imaging, so I'm going to give you a little bit of an introduction to certainly my perspective on ultrasound imaging and why it is such an interesting imaging modality to work with in the context of medical image analysis. So the learning to interpret ultrasound imaging is partly, it should have machine learning in there because I'll come on to talk about machine learning, but I'll also be teaching you a little bit about ultrasound imaging as well. So ultrasound imaging, it's normally the imaging modality people don't talk about. It's actually, it's always been grouped together with MRI and CT and nuclear medicine, but actually it's sort of increasingly the way you use it and the people you work with are quite different. And that's because it's an interactive technology. So rather than send a patient along to put them in a tube, normally, put them in the scanner, get the data back, and then get someone to interpret the data afterwards. Ultrasound is done on the spot by a very skilled person. You normally call them sonographers or sonologists. And they navigate with essentially a torch. They're going with a torch inside the body, trying to find certain structures. They're highly skilled people, and there's a degree of a training that has to go in to be able to do that. And it's the training. Everybody out in the audience today doesn't have that training, which is why in most papers you'll see people talk about ultrasound being low quality, noisy. That basically means you're not intelligent enough to be able to understand what the data is telling you. And what I'm really trying to do in my research is bridge that gap between the data that appears quite differently with being able to offer interpretations that can help doctors make decisions, and particularly the non-experts. The three examples up here, I'm not actually sure how well they are projecting. They're beautiful on my screen. They're not so beautiful from your perspective, I don't think. The three examples are the areas where ultrasound's used most widely. Ultrasound is the most widely used imaging modality in clinical practice. It's used a lot in screening. So the first point of call, it's used in cardiology, oncology, particularly in breast ultrasound and in obstetrics. And that's primarily because it's portable, it doesn't have radiation. And as I said before, the people who use the technology have to learn to interpret the data well. So my own research, I've got a background in computer vision, and my PhD was in computer vision. I then moved into medical image analysis. So I come at it from thinking about ultrasound, what information is carried in ultrasound data, and how can we as information engineers process that. The research has very much been shaped by going out and talking with healthcare professionals, identifying the needs. Some of those needs, again, using ultrasound can be quite different from the needs that you would meet if you were looking at MRI and CT in hospitals. And it's very much, you end up doing interdisciplinary research where the collaborators, they define the protocols, the acquisition protocols, so that's your input. They also tell you what they're trying to find, so they define the diagnostic criteria, that's your output. And then it's the challenge of the image analysis people to develop the analytics that allows you to bridge the gap between the two. And ultrasound, we both work with people in hospitals. The examples there are collaborators in obstetrics and cardiology, as well as work with collaborators in more rural areas and developing world applications where also the clinical needs are quite different. Julia Schnabel had this particular figure up. What's important, say from an information point of view, and information is in the end what we're after, is there have been some dramatic changes in ultrasound, and some of the legacy of this is still why people don't use it. If you go back, this is taken from a very good website which has lots of information about the history of ultrasound. And you go from sort of 1985, 1990, 1995, what you're seeing here, this is of fetal ultrasound scans. This is the fetus, there's the head there. The structure down the back, which you can hardly make out here, is the fetal spine. You see the change in definition of this over a relatively short period of time. Here, the spine is actually coming down here, and what you're seeing here that looks a little bit odd unless you know what it is, this is shadows. The probe is at the top, and these are shadows caused by as you would in natural images, shadowing effect, that all the ultrasound has been reflected back off those structures. And while from an anatomical reconstruction point of view, this is bad news, it messes everything up, just as shadows are a problem in computer vision interpretation. This, from the people interpreting the images, is the information that tells them and allows them to count the actual nodes in the fetal spine. So you learn to interpret the signatures, and it's that ability to recognize acoustic patterns that now in our most recent work we're really trying to use. So there were massive changes we've shown here over that sort of decade. Clearly, even in '85, which I know in some people's life is a long time ago, if you might not have even been born, but from the difference between here was dramatic increase. So that was when medical physics really, really drove improvements in ultrasound. But what's happened since then, or continues to happen, which I think is a bigger influence, on our field, is, you might even be surprised at that, because we normally talk about image quality being really, really important to the image analysis we do. But the biggest change is in terms of the portability of devices. And if you look at any ultrasound papers, they will talk about the portability being a key factor. Well, portability in 1998, this was actually the first ultrasound machine I bought. It's a great big chunky device, expensive device. It is now transformed that you get ultrasound. You still get ultrasound on these carts, but the actual ultrasound device is here. You get laptop-style ultrasound. You get USB plugs in, as shown here, and you get very tiny ultrasound devices dedicated for A&E type applications. So people are taught now, and it's been around for a number of years now, as you can do echo as being the new stethoscope in cardiology. This notion that it's digitized information, so there are thousands and thousands of ultrasound data acquired every minute around the world and stored in digital form. And the most recent factor has been again, the global need to be able to reduce the cost of imaging means there's a lot more focused on why people are not using ultrasound imaging, which a decade ago you wouldn't have heard. So this driver means now there's all these sorts of devices, but what hasn't changed is the fact that you still require a skilled operator to be able to use the technology. So we talked a little bit, in fact, Nicola Ayash was asked a question about the role of physics. Well, in ultrasound, the physics is quite nonlinear, and hence being able to incorporate that in image analysis has always been a bit of a challenge. But what's shown here is a classic ultrasound scan of a liver. The types of thing that we're interested in, well, what you're looking at is the modulus of the detected backscattered ultrasound signal, and that's why we call it echo. So a beam goes out, it reflects where there's acoustic impedance mismatch, and so at interfaces you'll get signatures coming back. It has a characteristic pattern on it, a texture, which is called speckle. This moves with the scatterers. It's not generally considered noise. It tells you a lot about movement of structure. It tells you a lot about different types of tissue. So speckle is actually a very important way to be able to characterize what goes on in ultrasound images. And in a typical ultrasound where the ultrasound here is what we call a fan beam, then you get this, the variable resolution, because the beam has been switched very fast across the image. And the other thing is that ultrasound attenuates with depth. So low down, you're going to have a smaller signal relative to further up if you pass through the same tissue. So those are the sort of factors that make ultrasound images different. They're always there, so they're predictable. And so again, if we're trying to build solutions, we should factor in that there is knowledge here that will always be repeatable. This then, if you can maybe see it, is an ultrasound scan, a video. This is the typical information that will be used by sonographers. If I let it scan, I wonder whether, Ben, could you just close that, see if it makes a difference? I'll run, thank you. Let me run it again, because I will be showing videos, and you'll all be imagining that I've got a great imagination. This is an ultrasound scan through this is a fetal scan. You might have made out the head, and as you go through, you've got different body parts. That is very typical. This is a very nice scan, I must say, even though you might not. So the challenge then is how data of this kind, with features of this kind, but they have features which are repeatable, how you can use computer vision, use machine learning to be able to extract the information. So I'll just run that once more. But the challenge, though, goes beyond that, is that when we take data, when we report results, this is shown for ultrasound data again, looking at fetal scans going from 17 weeks to 38 weeks of gestational age. So in other words, the fetus has grown over this time. What's shown on the top is what we would call good quality data. And you can this is of an fetal abdomen. You can make out there are structures here. The blob-like structure is the abdomen. You have information here about the ribs and also, and particularly the umbilical vein. You go from data in typical clinical use, from being high quality to medium quality to then the data when it's impossible to interpret. The challenge we have today is that most clinical publications will be analyzing data only on this top line. So all the reports you get of typical research in this area are from the best quality scans. If we're to get tools used in the clinic, we at least have to work on medium quality data. And so what we try and do is work with data within these two rows, be able to get methods that are robust enough to work in that scenario. My own group then has worked in all the areas I mentioned: cardiovascular, breast ultrasound, and also fetal ultrasound. So I was going to go very quickly through some of the sorts of problems that we've worked on in each of the areas, but spend a bit more time on the obstetrics ultrasound area, which is the area that my group works on a lot at the current time. In cardiovascular imaging, and this again was touched on by Nicola Ayash yesterday, the challenge there, if you're interested in looking at the heart, you focus on the chamber here, which is the left ventricle, and you focus on a characterization from the cardiologists of thinking about either characterizing the wall motion in what we call short axis scans, or through the 2-chamber, 4-chamber, and long axis. So in ultrasound, what you do then is you move the probe around to find these views, and then what the clinical practice today will be able to do visual scoring, or possibly using a small amount of automated tools to be able to look at wall motion, or inject contrast agents that allow you to look at tissue perfusion. So the sorts of problems that I worked on, particularly when I first worked in ultrasound, were sort of the classic ones of how you do image enhancement, being able to do 2D tracking, and also using Bayesian methods to be able to look at tissue perfusion analysis. And I just wanted to highlight one of the first papers that we published in this area, which was an example of Bayesian-based method. It was using Kalman filtering. And if you look at the output of its result, it works really well. And so what you're looking at here, you always look at hearts upside down in ultrasound because it's in the position of the probe. The cardiologists are used to looking at it. Sorry, it's just wanted to go there. If I play it one more time. But on this data set, it worked pretty well. But then, going back and reading the paper, this was the challenge. Bear in mind it's 1999. Is if you look at what the experiments were, you said a series of experiments were performed to compare tracking on different models, system dynamics and training strategies. So we looked at different models. We acquired data on an HP Sonus 1000, which was sort of a machine around at the time. The data, though, was VHS video and digitized, which dates it. But most importantly, data from one normal patient and one abnormal patient has been used throughout this paper. So at that time, this was acceptable to be able to, the early days of being able to get any methods. Clearly today, anything like that would not be acceptable, and we're much more interested in seeing how techniques of similar kind can work on thousands and thousands of examples, which is what people do today. Other sorts of work we've worked on, MRI and ultrasound fusion. The motivation there is to look at how, with non-rigid registration techniques, you can benefit from the nice anatomical definition provided by MRI and complement that with the real-time nature. If you look at the example over here, the one over here, and you focus here, what you're seeing is that having registered the MR and the ultrasound, you can see the valve moving. The green there is the ultrasound superposition. It allows you to look at the valve dynamics together with the anatomical definition of the MR. Around to about 2000 was a very significant point in time for ultrasound when, and I have an example of some of the data we were using in that, this was from 2001. This was with a contrast agent injected. You inject contrast agent to where the agent reflects from ultrasound, so you get this nice white definition of the boundaries. That simplified the tracking. So you went from data of this kind that was almost binarized to be able to go from linear array data with 2D probes to be able to get matrix array, so to move to acquire 3D data. And this is just a slice through the typical data, 3D data. And although you can get higher quality today, this reflects it at that time. So it's a very, very exciting time. But as with lots of introductions, the introduction then introduced its own problems. And particularly the notion then you had 3D ultrasound acquisition, and there's a timeline here to the person who you're trying to impress is the sonographer. So the time that they would go from scan to decision is shown here, with green being the scan, red being the decision. The idea that you did a 3D scan didn't solve a problem, because then they had to manipulate a 3D volume to be able to get these views they were trying to find. And it was a very, very slow process to manipulate 3D volumes to find diagnostic planes. So where there was an interest in our field at the time was how do we go from 3D acquisition and use image analysis to be able to automatically find these planes. So you acquire data, quickly do the plane finding, and then recover the diagnostic planes. In this case, it's only when you do this do you start to introduce a solution that's going to be acceptable in clinical practice. And a number of groups have worked on this problem, and from my perspective, I think it is in some sense solved. You do not see it, to my knowledge, in commercial systems, but at least widely, versions that are widely used by clinicians. There have been some prototypes put together. But one of the ways you can solve that problem that we found successfully, and you've heard about these techniques now, using, in this case, a class-specific regression random forest. So the classes, you learn from data where you've manually found the planes you're interested in. That introduces the class-specific feature, and then you can use random forest to be able to learn for that given plane what's characteristic of the different intensity patterns and use context features, etc. And this was a paper that we published 2013, developing a technique. What's shown here then is a comparison of the manual plane extraction with the class-specific one, And even though you're not experts in ultrasound, if you start to see, you're trying to recognize that you have similar acoustic patterns around these chambers, you can see that from an appearance point of view, the images are quite similar. You can also translate it into millimeters and angles, which is what in our field we like to do. We like to quantify. If you present this to clinicians, they're not so excited by it because they don't actually find planes and use these numbers. What they really care about is can they find the diagnostic information quickly. And another example of working with 3D ultrasound, what it's allowed us to do in the field is to go to 4D, so that's 3D plus the time dimension, do 4D analysis. And in our case, we have used some machine learning methods to be able to help with identifying the correct boundary responses, and then use model-based fitting, both for looking at the left ventricle, which is shown here, and more recently the harder geometry associated with doing right ventricle analysis. So that's showing you cardiology. Another example, as I said, is ultrasound used very widely is in breast cancer and oncology screening of other conditions as well, but particularly ultrasound. And in the what's called the clinical pathway of a patient who goes through a breast care clinic, then it will start with identifying that there will be suspicious mass by clinical examination, or you pick up by X-ray mammogram, and then after that, if there is something suspicious in either case, you're referred to a clinic where you do an ultrasound. MRI is used for younger women, and if either the ultrasound or MRI still looks suspicious, you'll then go for the biopsy, and then if cancer's found, go through surgery, etc. So ultrasound is really key in the middle, and its role here is to be able to do characterization. And while you can look at ultrasound, and some of the things we've done in the past is look at segmentation of masses, look at reconstruction this is freehand ultrasound, where it's a 2D probe, you track, you reconstruct in 3D, and then you can visualize the mass to try and get a notion of its size. The work I was just going to highlight as representative of where ultrasound can be useful is in the area of tissue characterization. And ultrasound this is using ultrasound in a slightly different way, because you're not using the B mode, the ultrasound images I've shown you before, the echo images. You're using ultrasound as a means to derive information about the strain or displacements of objects, and then you're using that information to help make a clinical decision. So there's a history to this. It's sometimes called tissue elasticity imaging. It fundamentally comes from the idea that if you compare structures in the breast that are around a mass, you might have, you've got fat, you might have glandular tissue, you might have fibrous tissue or cancerous tissue. If you look at the Young's modulus, which is your elastic parameter, then if you look at what's been measured in vitro studies, you can see that there is a range of values reported, but in general, there is a difference between cancerous and the other structures that you're not interested in identifying if you're trying to characterize cancer. So what this has led to, and it's become quite an advance in terms from a technology point of view, perhaps less established in clinical practice, is moving historically from manual palpation to doing visual assessment of images. People moved on to look at imaging strain. Strain, of course, is the rate of change of displacement. So you're looking at what's called strain elastography. People often drop the first word in there and call it elastography. And there are some very nice advances to that since, but very expensive ways to compute related properties, shear wave velocity, which I'm not going to talk about. And then this notion here, the motivation always goes on to say you should go about computing quantitative reconstruction of mechanical properties. We've looked at the latter, the last one, but our radiologists have no idea what a Young's modulus is. and they weren't particularly interested in telling us, us telling them what the Young's modulus were. They were interested in just being able to understand quite simply, can we find a cancer or not? The basis of these techniques is simple, illustrated incredibly simply here. You apply a force to the tissue, you increment that force by a small amount, that displaces the tissue, and if you look at the radio frequency signals from the ultrasound, you'll see a shift in the pattern, so you can use different ways of estimating displacements based on window-based techniques to do that, and in particular, this is where that speckle pattern comes of its own, because with the speckle moving, because the speckle pattern relates to scatterers, you can use that. You have a really nice signature to be able to estimate displacements very accurately. If you wanted to go the whole way, you'd have to go and look at tissue deformation models, assuming it's linear or non-linear, and then solve the inverse problem as well. And of course, there are issues in solving inverse problems. So the point I wanted to make about the work we were doing in this area is the importance of working and listening to your end user, in other words, in our case, the radiologist. Because we started to work in this area, I had an excellent PhD student at the time, working, Mike Cador, who's shown there. This was the device that was built, which is shown schematically here. Very, very simple device. This is an analogic system. You hold the device over the woman's breast, and then it moves in very small increments. And what we were trying to do was simulate what the radiologists here told us was important when they made the decision. They look, they palpate. If you compare palpation, which is not using imaging with imaging, they use the ultrasound imaging, the B mode, to look at size and shape. They use strain imaging, the elasticity imaging, to look at stiffness. But that alone wasn't going to be good enough for them, because what they also look at is the mobility of the mass. So what Mike decided to do was to develop a way of detecting the slip, which he called slip imaging, that meant that we could present not only information about the ultrasound image, but there's information about the stiffness, and then there's information about the amount an object slips. In fact, let me just show you. I think this video works. So the type of information you'd present is just color-coded here. This is the ultrasound. This drawn on here has been drawn from here. So you've overlaid the area that was stiff on the B mode. The important thing here is to see that the two don't overlap, because they're complementary information. This is telling you about strains. And then you've got this color here is showing you whether object is slipping, or in this case, the middle is not. So why was this a sensible way to look at this problem? What you've got here are the three, I've simplified it slightly, but the three different types of mass you might find in breast cancer. You've got cyst, fibroadenomas, so that's fibrous structures that are benign, and then an invasive cancer. And if you look down this column, this is what traditionally radiologists would be presented with. This one's not too bad. Cysts are sort of water-filled or liquid-filled little sacs. They have a characteristic signature. And they also, if you come to elastography, because you compress the tissue, you'll get characteristic buildup of strain. They don't worry about those. They don't worry about them because they can see them. They don't worry about them because it's not a cancer. The hard ones are distinguishing these two. And if you look backwards and forward between the two, by eye you can't distinguish them. And it's for this reason that 80% of the biopsies that are done lead to the conclusion that the mass is benign, because they can't just pick out the cancers. So here, the difference if you do elasticity is you get this signature, so that means we can find cysts, but you're still left with an issue. These are just two examples, but which here look a little bit different, but you still get this characteristic stiffness on a fibrous structure as well as a cancer. Whereas if you go to slip, fibrous structures do slip around, which is what you're seeing here, whereas cancers infiltrate and do not slide around. So that was the basic idea. Have a clinical indicator that was exactly what the radiologists do in practice, but translate that into an imaging to try and make it easier to do. So this is just summarizing the results, which I'm not going to go into into detail of because it wasn't the purpose of my talk to do so. But what you find is by adding this slip image, you can increase diagnostic accuracy from, if you use the ultrasound alone, 76%, about 78% if you add stiffness, and it goes up to, again, if you add slip. It allows you to pick out the fibrous structure as well, but unfortunately some cancers also do slip around, which is why you can't introduce it directly into clinical practice. But interesting, from an interesting observation from the clinic, it's an example of translating through to using new image-based information to make decisions. And a final one that I'm throwing out as for anybody else who's sort of interested in this general area, because we haven't taken this work forward. This was some pilot work we did of using strain imaging, using the same device or modification of it, during taking ultrasound scans during chemotherapy. And what you're seeing at the top is, in this particular case, that the mass shrank. But what you're seeing at the bottom, these are the elastography images. You can see that there is quite a different change in the pattern of the strain, which relates to the biomechanical properties, particularly in the surrounding of the mass, have changed over time. So here what you're really looking, or you're interested in, is the heterogeneity of the surrounding tissue. This is the important clinical indicator. Radiologists were very excited about seeing these images. So really what I believe is an area that would be very interesting to look at if you could build the databases to do this, is to see how you could use machine learning with this sort of longitudinal data to understand if you could describe the rate of change or the success of the given chemotherapy from images of this kind. There's no alternative today for doing this, because the way you really look at change would be by doing histology, and clearly during a chemotherapy or during any therapy, you cannot take histology, otherwise you've changed the whole process. So being able to use ultrasound would be a really good way to be able to monitor how a given therapy works over time. Okay, so that's sort of just giving you really the warm-up to what I wanted to talk about. What I really wanted to be talking about was the work we've been doing recently. This is probably about the last 6 years or so in the area of fetal ultrasound. As I said right at the beginning, it's motivated by what I call Western world problems. In Western world, women generally come for a first scan at 12 to 14 weeks to date the scan, and then if there's any risk in pregnancy, they are monitored from then onwards. If you go to developing world, women do not go for any antenatal checkups at all. In normal practice, they only go when they're very, very sick, which means you see extreme cases of problems in pregnancy. And so the whole need for technology, the whole ease at which you use systems and what you want to measure are quite different in these two environments. If we look at the data, this is a cute little example, typical of 3D ultrasound. This is a little baby that suddenly becomes very tired in a few seconds and rubs its eyes and goes to sleep. If you watch, I'm about to do it now, I think. There we go, going to sleep. This is very typical. This is clearly the head. You can just about pick out moving here. There's a heart. And this one is training for the Olympics or something by doing exercises. And that's a very, very sort of classic view. So this is data you get either 3D ultrasound, but that's not so typical. Most of the work in the field will be done with 2D ultrasound. So the data, if you're not used to it, looks really hard. But when you've seen about 20 of these, they all start to look the same. You get these characteristic signatures around the heads, for example. You pick out, there's a little texture pattern here that, at least in this case, shows that the baby's alive. So there are really important cues that are used for interpreting this data. So I've set up a very large program now. We've looked at all sorts of problems. It's focused, partly we look at automation of biometry, but that really isn't the most exciting research. I think we've worked with clinicians on defining non-conventional scanning protocols, and I'll talk a little bit about that. We've worked also on trying to study the brain, and I'll show you some of the work we've been doing in that area. And what we're really trying to do is push the use of ultrasound in terms of its ability to derive imaging biomarkers. The work here that I don't have time to talk about is how we've looked at the amount of fat in soft limbs, as, how that correlates with nutritional health of a fetus. And then the examples shown around here are all to do with brains and faces, and how we can start to look at ultrasound and its application to look at the developing brain. My work has very much been motivated by and interest started by my association as being on the steering committee of an Oxford-led project called Intergrowth 21st. It was a large Bill and Melinda Gates Foundation project. Its goals were very, very simple, and it was obstetrics goals, were to come up with fetal growth charts. Now, they exist today, but they are for populations, and by being population based, they're often derived from local communities, and also can be a mixture of healthy pregnancies and ones that are not healthy. What was special about this study was they took sites around the world, they're shown here, so all the major continents were involved, so there were 8 sites around the world, and they recruited women who were defined under very strict criteria of a healthy pregnancy. And from that, they've come up with Crfs, which is the first time it's been done, which are that describe the optimal way a fetus grows anywhere in the world. There were 2014, there were 3 Lancet papers that described various aspects of what they do. Part of it's looking at the fetus and also early life. What was special for me for being associated with this project is I had this opportunity to talk with people from around the world about what the real problems were in their area, and also understand a lot more the ultrasound data, which I'll come on to in a minute. But this project, you know, it's been quite influential. Last month, for example, with the Zika virus, the Crfs that they've derived for head circumferences for neonates are now being adopted in Brazil under the recommendation of the World Health Organization. What is really special about this is the careful study they've done, the careful study, the characterization that's been done around the 5,000 pregnant women. In ultrasound terms, they have taken standard measurements. This is the femur, as shown here, the abdominal circumference and the head circumference. These are the basic measures that people use every day to assess pregnancy around the world. I think from our point of view, this seems a little bit strange because they're all size-based, and in most other areas of medicine, you wouldn't use size as an indicator of health, but the state of obstetrics is still very much at that domain. So they've acquired this data, and it's on 5,000 healthy pregnancies. Each woman scanned at 5 points in pregnancy from the different sites, and they've also got 3D ultrasound scans. And it's this large database on which my group has access to has allowed us to start to look at machine learning and also work on some quite unique problems. So I was going to show you a few examples of the types of thing we've done. Most of these will involve using sort of recent machine learning algorithms, and I'm not going to go through the details. If you're interested in those, you can either look at our website, and I've put the references on the slide as well. This is an example of using random forests, published NICI 2015. And the goal here was to be able to design a method that could annotate typical ultrasound images that would be acquired for biometry measurement. And the ones that a sonographer would do, and in fetal ultrasound, because the fetus moves, you don't have these taken in an order, so that's why you have to go through the annotation process if you want to look at them later. You take measurements on the head, the femur, the face, or where you look at the face, you look at the spine, you measure on the abdomen, and you also do a heart. And what we've developed then with those classes, you can then design, and this particular algorithm uses thousands of real-world data to do this. The goal then is, if in clinical practice, you were taking these measurements on, if you look at the images here, rather than the boxes for now, these are all examples where measurements have been taken or characterized on the spine. You can see they vary a lot in their appearance, their scale, their position. And similarly, if you look on the heads, this one is generally a little bit easier because it's stricter definition for measurement. As it goes, it runs through. I'm not sure that one's flicking over so many examples. But you can see the heads in different positions. So it's a challenging problem that prior to machine learning, I don't think you could really attempt to solve. And that's because of these appearance of the images. But with machine learning, and being able to use the power of that to look at to build knowledge of what the characteristic patterns are, then you can start to analyze the data. If I now go back to this example, the boxes that you might be able to see, there's a blue box here that says it's found a candidate spine. The yellow one says it's found a candidate femur. What you find on spines, if I run it, is that there are quite a lot of structures that, well, if we skip over the first one, I think, quite a lot of structures where that yellow, for example, there, it's moved on already, but you'll actually see yellow objects that do look a bit spine-like. So it goes through the process here, you've got straight lines, and then it will go through the process of doing the hypothesis and eventually finds the right object. And when you look at heads as well, it likes again to think that there's femurs there because it's got the linear structures, but it will home in on the solution. And part of that's when it starts to use those internal structures that are unique to what characterizes a brain. This particular method, just as quite quickly, the key to its success was really in the way you define the feature sets. You have to get rid of a lot of the clutter. You have a set of templates that allow that through normalized cross-correlation you approximately match, and then you can define sort of a multi-scale version of feature extraction, which is done by block R features, allows you to characterize in a very rich way each of the possible regions over different scales. And then it's through that, then using those features within the context of random forest allows you to build a very robust solution. In terms of accuracy, these were the results as of MICI. The overall accuracy over all these different, for detection of all the different classic views is 91%. The guided version using the template is an improvement on 79% without, under similar implementations. And as you probably expect, there is a variation and a boosting effect on certain structures. Here particularly, there are two head views that look similar, and when you use the guidance, that helps to separate them. And also here, the spine detection is also much better because it gets less confused with the femur. So that's one example. An example now I'll move on to, which is, was a problem that came from my clinical collaborator, Aris Papageorgiou, who works a lot in Kalifi in Africa, was to say, well, can we provide tools that could help support decision making in the sorts of environments where his colleagues in Africa worked? And the biggest challenge there, or in terms of a clinical problem, their problems are quite simple. So a simple one that you would very rarely see in Western world is when mother turns up, you've never seen her before, she's unwell, you sense that the fetus is unwell, and the person who's got to make the decision is not an expert sonographer. So the simplest thing that's useful for them to know is the baby's head down or is the baby's head up, so this is normal position for delivery. This is what's called breech presentation, when the baby's not positioned correctly. And this is very important for risk assessment. So for us, that's quite a simple problem, because if you could scan over in this direction, take scans, then it translates to the problem of being able to find the region in the video where you found a head. Is the head at the beginning of the video, or is the head at the end of the video? So the key thing here is rather than use the traditional way of doing ultrasound, which is have an expert, they move around the probe, they do some clever movement of the probe and then interpret what they see, we're saying let's not do that. Let's actually just move to a very simple protocol that anybody can be trained to do. You just have a certain time, you go from here to here, you go in a line. What can we then interpret from scans of that kind? It started out by looking at breach, because we thought that was a problem that we could address, and you could imagine you could solve that one, but we've also moved on now to try and understand what else we can extract from videos of this kind, because it's so simple to use that anybody anywhere could use it in the context of making decisions in obstetrics. So the video I showed you before was one of those examples where going through here, as you go through scan, that's the head, and then you're going through the body. So that's an example. And you're seeing the limbs. So translating into the image analysis, I mentioned this work in my previous lecture. We developed a way that essentially will identify the skull, the heart, the abdomen, and other body parts. So as you're scanning across, you can then learn to recognize individual frames. And what's shown here is just the ground truth in the middle, and then some different approaches we've developed. You can either, if you do a frame-by-frame classifier, as you'd probably expect, you occasionally make errors, and hence, in our case, we use CRFs to be the conditional random fields to be able to smooth the result. But here, you've at least got the, you go from scanning the head to a body part that you're not interested in, to scanning the heart region, to then scanning the rest of the abdomen. So it's a very, very simple way of partitioning videos that is then useful to try and make other decisions. And some of our work is actually looking at doing that. So that premise then, we've looked at the work I showed you before was using support vector machines with using the bag of words type approach. It was used in some of our early work, but it allows you to go through and annotate videos of this kind. And some of our most recent work, just to show that I also work with CNNs, and most of my lab now works with CNNs. This was some work published this year. I won't go into the architecture, but it was a transfer-based method, and using about 323 videos of our current database, you can get a detection at about 92%. Much, much better for the challenge is the heart. The challenge is for the heart is because the heart is very small, so you don't have many samples of it, and the sampling of it is not very accurate. And of course, hearts appear in abdomens, so there is an issue as well in how we define them, and those are the sorts of things that we've been working on most recently. What's shown here is the work that I've just mentioned, this path A. Take the data in, simple scans in, do classification, then from that predict frames. Some other work that we've done very recently, this is work of Ali Marassi and Chris Bridge. Chris has been interested in how we analyze fetal heart videos. And one thing that we've now developed is a way to detect in these scans that the heart is beating. So we can now do what's called a two-step process of determine whether a fetus is breech, and then do a simple viability test to see if the fetus is alive, all based on that very, very simple suite. Chris's main work, though, has been looking at how we can start, again with video, is how we can start to describe fetal hearts. And fetal hearts are hearts. They're relatively similar to adult hearts. They are clearly very tiny, which means it requires even more expertise to be able to do the scanning. And they also have a slightly different anatomical structure as well, because there's a part of the chambers join up post-birth. But basically, you've got the same issue you have with adult cardiology of that the person who's checking the heart, checking its anatomy, is expected to move tiny little movements to be able to get views that might look like this. And as you see here, they are very much blob detectors and context-type blob detectors. And what Chris developed was a way of a very nice way of taking three of the views shown here, four-chamber, the left ventricular outflow tract, and the three-vessel view, and translate that into a Bayesian-based method of being able to estimate which plane you're in and which phase of the heart cycle you're in as a cardiologist moves the probe. How did he do that? Well, say the basis of it is that you've got someone to carefully acquire those scans. So we've got ultrasound video, 2D video as they've moved the probe, and then he goes through extracting rotationally invariant image features. You need them to be rotationally invariant because the fetal heart can be in any position. And then from that, he uses random forest-based technique to determine which view, to localize the heart, so find its center, to determine the orientation of the heart, and also determine the phase of the cardiac cycle. And part of it is then refined using a temporal model. What I think was most interesting about his work, it's the first demonstration ever that from videos of this kind you can extract a useful descriptor from these very, very challenging types of image. So he posed this then as a state estimation problem. It was heart location, view label, heart orientation, and a current cardiac phase. How you visualize that is you've got a color showing you which is the plane. The center of the circle will be showing you the location, and there's a little arrow here that's showing you the phase. What I'm going to show you here first is, and someone is moving the probe, what I'll show you first is, this is the ground truth, the reference that's been annotated by an expert. This is his algorithm, and I'll show you this one first. Or will I show you this one? I'm not sure what's going to happen. Yeah, I will show you this one first. I wasn't sure they were all going to play. As you can see, if you do it frame by frame, it's jumping around. Frame by frame methods often do. It does actually get a lot of the labels right, but it is moving around. And what the temporal version of that does, if it will let me play, is it starts to work much better. That using temporal information allows you to refine the labeling where you haven't got the consistent labels. So that's an example then of looking at hearts, trying to make sense also of video within the context of developing world. We've also done some work with, and this is work that's just starting, working with Peter Hammond, who's recently come to Oxford from UCL, and he's a world expert in face analysis for diagnosing conditions of young children using shape analysis, and particularly looking at children who have different, often rare syndromes. So you look at their faces and you can come up with these heat map that allows you to describe how the standard deviations and the deviations from normality, and it might, for example, be related to the separation of the eyes, to the fulcrum, and to the profile of the child. And he's an expert in this area. He does some really, really beautiful work. But what he came to talk to me about was, could we start to do that sort of analysis in the fetus? Because if you're going to intervene and be able to intervene for some of these conditions, you need to have that information from fetal scans, particularly for a condition called fetal alcohol syndrome, which is due to mothers drinking alcohol during pregnancy. So we have started to work on this. We've started with just basic, now quite standard methods of extracting profiles from fetal alcohol syndrome data, and from that you can then reconstruct faces, and some very early work shown here on how the fetal ultrasound data can start to be correlated with some of his shape analysis. But the other reason to work with Peter was to think about what's the relationship between shape of faces in the fetus and also the underlying neurological changes. And one of the key structures that is of interest in the developing brain that's certainly related to fetal alcohol syndrome is the corpus callosum. And so what we've started to do, again, thinking about machine learning-based approaches, is to try and extract shape features. Now try to extract the corpus callosum. And the corpus callosum is actually, it's probably quite difficult for you to see, it is a small structure. It is actually very difficult to determine locally. But it has this maximal stable extremal region type of shape. So, and some of you will be talking with me about a paper on this topic later, but we took the ideas that we've applied elsewhere to see if we could use that as a basis for extracting what appears to be an incredibly hard structure in 3D ultrasound data. And this is work in progress. It's actually just been published at a small meeting recently. But what you're trying to do then is the goal is to extract a structure in very, very complicated sonographic patterns. But if you've got some examples of these, you actually start to learn what the characteristic context patterns are. We use the MSERs, which allows you to characterize approximate shape and then characterize intensity patterns around that, and are starting to get, in terms of region classification, some quite accurate results at determining the corpus callosum and the related structure shown there. But using a lot of neuroimaging now, particularly for the developing brain though, is not based on ultrasound. And one of the things we're trying to do is try and raise that profile of using ultrasound as a useful imaging modality in the context of the developing brain. If you look at or any literature, you type into Google Scholar or whatever your favorite search engine, you'll find, and you try and look at developing brain imaging, you're most likely to pick up in, papers that are associated with MRI. And if you look at MRI, this is showing gestational age from 23 to 37 weeks. You now start to get some very nice images and also some very nice analysis work being done that's describing the developing brain. Now, ultrasound equivalent looks like this, and you might look at that and go, why would anybody ever want to do anything on data of this kind? It's different. You're posing the problems you look at, the solutions you come up with are going to be totally different. Why you want to do it is if you're going to be working in clinics and pick up neurological delays, neurological conditions, you need to be able to get solutions that work on ultrasound. So this, if you're working with data of this kind, what you're really saying is, if you translate from the scientific point of view, is what you're asking is, are there unique sonographic signatures or patterns which tell you how well a given brain is developing? It was an unknown question before we started to do some of our work, particularly looking at interior patterns, but we decided to see if we could get machine learning to help us. The person who was working on this was Anna Nambarati. As part of her PhD, she was working with the clinical fellow Bryn Kemp. And Anna was born in Mozambique. When she worked in my lab, she said she wanted to work on a problem that was related to something important back home. So one of my main collaborators was going out to Kenya at the time, and I said, can you come up with a problem that Anna could work on? And the problem he came back with was the following. It says, can you estimate the gestational age of a fetus for a mother presenting at the clinic for the first time late in pregnancy? Why this is so important is that all these size-based measures don't work very well. By looking at the maturity of the brain, of the fetal brain, that gives a much better assessment of the strength, if you like, of the fetus and whether it will survive delivery. So I said, yes, we can look at that problem, having no idea whether we could solve it. And the solution that Anna worked on and came up with is the following. So we used the big database I've mentioned before. That's the Intergrowth database. So we had a large, very well characterized database And particularly by well characterized, I mean, we had volumes at each day of pregnancy, and that then allows you to think about how you could build a regression model that would allow you to map the day in pregnancy to the image acoustic patterns that you'd see in a 3D ultrasound volume. So we have this very large database, and that then forms your training data set. If you pose this as a regression problem, in our case we used random forest because that was, at the time, that was the obvious technique to use. You can then develop the solution that allows you to then train, go through the training process, and I'll show you briefly the key elements of that on the next slide. And then that means if you've got the true age, or in our case it's really measuring the maturation of the brain. If you've got that, we know that because for our particular data set, they know it, all the mothers knew their, what's called LMP, that they knew the exact, you could characterize the actual day of pregnancy that's been correlated with an ultrasound measurement. And then we could build this model that allowed us for the unknown, new example, to be able to estimate the gestational age. So that's the basic idea, and it was described in a medical image analysis paper in 2015. And sort of how she was building the solution, she was using some of the classic features you'd expect to use, all implemented in 3D. You have to position, you have to know where you are in the coordinate system of a brain, so she had to have a method that allowed you to put that coordinate system on the brain. And then also used context features, particularly using knowledge from the literature as to where in the brain there might be structures that are developing at a given point of time, allowed her to design a set of features and feature positions that could then be used to look for the sonographic patterns that were important for characterizing or for age discrimination. And then, so having thought sort of carefully about features to use, she could then build the regression forest to develop the solution. Does it work? Well, what's shown here is in the blue on this side is you've got the true age versus the predicted age. The blue example is measuring based on head circumference. And what you find if you fit ellipses to ultrasound data as a measure of manual head circumference, then later in pregnancy, which is the time we're interested in, you get the deviations from the true age from the predicted age. So exactly in the area that you require the solution, the conventional metrics do not work. This is well established in the literature. In her particular case, though, this is showing her model. You can see that in sort of throughout ages, you end up with a very good fit. So this machine learning solution is more accurate than the current gold standard, the one shown here, particularly late in pregnancy. And it was just using a standard clinical scan. We didn't acquire this data specific for the study. All trained sonographers can acquire the 3D scan. The other thing that was interesting sort of as a side thing was by using random forest, you can go in and you can look at what features were used to make decisions at which point in the tree. And what you find is that the key sonographic patterns that really drive this particular method, they correspond to the known anatomical structures that from particularly MRI and also anatomical studies have shown are important for early brain development. So what we were actually starting to do, which I think is quite interesting, is from an ultrasound point of view, recognize patterns in these scans that radiologists could not recognize. So start to get information out that goes beyond the radiologist's eye. So that's showing you some of the work we've done on the fetal. The last sort of area I wanted to talk about was using ultrasound as a technology more broadly. And to start by saying, what are the biggest needs worldwide to make sure that ultrasound can be used worldwide? What changes will be valued most? Is it changes in quality? Is it miniaturization of the device? Is it anything to do with new acquisition technology? Because we've already got to the point of having a device like this, so why is it that ultrasound's not used everywhere? What I said right at the beginning is, even though you can put all your emphasis in the technology, if it's still a technology that requires experts to use, that's a problem, and it's never going to really take off and have wider adoption. There are training programs, lots of training programs, but the demand and need exceeds the training programs, and what people find is people go on training programs and then they lose their skills, and in practice they're not being monitored in the real world. And the example I showed here was from real world data that had been used to acquire. What we're really most interested in, and one of the sort of academic questions I'm now very interested in looking at, is why do some sonographers scan better than others when they're all supposed to be following the same guidelines? So for me, the biggest unmet need is not getting higher quality images. I think the images actually are fantastic quality. Humans have a problem interpreting them, but that's our problem, not ultrasound's problem. We need to understand how to do that better. But the real challenge is from the acquisition point of view, that if you look at, you think about performance of people, you look at skill level, you have this distribution of abilities to be able to scan well. And what we really want is everybody to behave the same way, to go over here. So that's what we're trying to do. Some of the work I did quite a while now. We first looked at it in 2002, but then we had a flurry of papers sort of 2007, 2010, was starting to look at this and work with, or look at what sonographers do. What sonographers do is they move the probe around a small amount before they press the button and save the data. And if they do that, they seem to do a very good interpretation. So from that observation, my conclusion was, well, why are we making computers only work with one data set, the finer one? Why are we not letting the computers work with the few data sets before that? And at the time, because you've got a lot of work on registration, that led us to look at how we could do ultrasound fusion. So ultrasound fusion takes scans from slightly different position, and if you just compare these two, for example, you can see along this border, by moving the probe, you see slightly different definition of the borders, and then you can run through registration, and there are lots of techniques to do that. If we now put all the scans together, you can see now a much nicer, this is just averaging at the bottom, I'm not sure it's going to let me play that one as well. This is showing you a very nice definition now, all the way around all the chambers. This is the left ventricle, you've got the atria at the bottom, and the other chamber. So you've gone from the mental fusion that sonographers do to now computer-based fusion. We're using now quite standard techniques of registration. Does it make a difference in clinical practice? The answer is yes. This is a study we did with clinicians who were interested in grading, looking all the way around the heart boundaries, grading whether they could interpret them. So they would say that they were good for interpretation, intermediate, poor, or out of sector, meaning you couldn't see it. And in the best single view, you ended up with a pie chart that showed you, if you took good and intermediate as being acceptable for automated image analysis, which was my definition at the time, then it was about 67% of the data we could use, and we'd struggle with the rest. And if you do this technique of putting multiple scans together, it goes up to 95% of your data is usable for image analysis. So pretty impressive improvement. And in fact, we also had publication, which was the obvious one to do in some sense, to show that then running medical image analysis, segmentation on this data, led to a lot more reliable results than if you work with a single fused data set. Sort of stating the obvious, but putting numbers to it. You can do the same thing for fetal ultrasound. The problem here is your little object likes to move, so you have to pin it down. So here was an example where we were very, very interested in characterizing what goes on at the end of the femur. It was part of a large vitamin D study where the growth at the end of bones was very important. And if you look at in a classic ultrasound, it all sorts of fades away. So what we did was we took multiple scans, fused them together, and then compared with here, you've got a better quality, slightly visually better reconstruction here. It's very difficult to determine by looking at images. So through a special study, which was a terminated pregnancy, for which we had to get special ethics approval, we scanned a fetus with ultrasounds, and then afterwards with CT, so we could use the CT as the reference. And what you can see here in terms of numbers is the CT, which you could say is the true volume, which is 405. If you compare it with any of the single views, the volume you can compute, these range from 314 to 375 millimeters cubed, whereas if you did the fused one, it's 407. So compared 405 to 407, just shows you the value of moving the probe a bit to how quantification can improve. So that's just a sort of a really, really simple example of saying, if we think a little bit, we can do so much better. And that is by taking what would be variables. So if each of these people had done a single scan, we're now saying now they can all behave as one. And that, of course, from a medical image analysis point of view, really simplifies what we do. But if you look at this figure, I've stayed up with people who are highly skilled. What we really want to do is we'd like everybody to be an experienced sonographer, including yourselves and the audience. So what we really want is people being skilled, being not so skilled, and have high performance. So how can we get there? This is something I don't think anybody has a solution for. I'm hoping I will develop more solutions for it. I've just got an ERC grant to look at this problem. And what we've gone back to do is think about, try and understand more, why do sonographers do better than computers? And one way you can do that is by using the information they haven't told us about today. They'll look at images, they'll tell you what they've seen, but they will not tell you where their eyes have looked. And so what we've been doing over the last couple of years is we've been using eye tracking technology to look at eye movements as we ask them to interpret images. And I was most interested to see what features they look at which they're not telling us about. And of course, they said they tell us everything, and of course, we find out from the tracker that that's not true. So there are now cheap eye trackers that you can use because it all comes from Advancing Gaming. This was some work we did by trying to, for people to be able to interpret and do characterization and grading of abdominal scans. And what they tell you in the guidelines is that they look for the umbilical vein and they look for the stomach bubble. But what they don't tell you is that everybody also looks at the spine. So in this work, we've compared using, including graphical model techniques, but also using AdaBoost was the example shown here, building detectors that just detect the stomach and vein, and also using information about the spine. And what you find is that you improve the overall detection rates. Under my ERC program, we're taking this a lot further, which I hope to report on later. So just to summarize, I've given you a bit of a large overview of where ultrasound is. My lab is one of the largest labs looking in this area, so it'll give you a flavor of the things that people are thinking about. You can use ultrasound to discover new biomarkers. I think there are big opportunities there to use the machine learning-based biomarkers from ultrasound. In our case, we are working a lot now in fetal neurosonography, looking at fetal brains. I think there's a role to better understand how we map the sonographer, the person doing acquisition, how we use knowledge of what they do, put that together, and embed that with image analysis solutions. And then the other area we work on, which is aimed at working in the developing world, is really trying to simplify scanning, introduce new protocols, and let the computers do the intelligent interpretation that we all talk about. So really, it's the interplay now of ultrasound, not just reading images, not just being, ultrasound is the same as MRI. Hopefully, I've given you a flavor of how it's moving away, how it's building on its strengths as well. I think the really exciting area is this interplay of ultrasound and both computer vision algorithms, but also the human interaction part will advance the use into clinical practice, which is what we all aspire to do. And it's entering a really exciting new era. So thank you for your attention. I'm very happy.